And we're going to kick off with a talk from Mr. Matt Parry, who is a very valued colleague who's done some wonderful work in the National Prostate Cancer Audit and was previously working with us as a clinical fellow. Matt is a urologist by trade and is going to give us some of the findings of the National Prostate Cancer Audit in this variation for men with potentially curable disease. Matt, thank you so much.
Thank you, no problem. So I'll just share my screen. So yeah, hello everyone. So as Heather was saying, I'm Matt Parry and I'm a urology registrar currently working in London. So I was previously the NPCA research fellow, so this was a few years ago now. But during this time, we did some work that was essentially looking at variation in the use of radical local treatment for men with high risk and locally advanced prostate cancer. And this provided some interesting results and essentially why this became the topic for discussion at this NPCA quality improvement workshop. So essentially I'm going to begin the session by going into a bit of detail into why this was an important question for the NPCA and some of the results that we found. So as an introduction, the NPCA started in 2014, and since then we've been reporting on annually on key performance indicators with respect to important aspects of prostate cancer care. So one such performance indicator was the potential undertreatment of high-risk locally advanced prostate cancer. Now, the rationale for this indicator was that radical treatment is clearly advised for these high-risk cases in order to prevent prostate cancer death. However, treatment decisions are difficult when trying to identify appropriate patients in terms of their fitness for treatment and their estimated life expectancy. Life expectancy of at least 10 years is generally regarded as an appropriate cutoff for whether radical treatment is appropriate or not, but estimating life expectancy is not always straightforward. So at the time of writing the paper, figures from the NPCA showed that in 2017-18, over 47,000 men were diagnosed with prostate cancer in England, and that 41% had high risk or locally advanced disease. Essentially, 4 in 10 men have potentially deadly but treatable prostate cancer at the time of diagnosis, and 68% of these cases received radical treatment. And this essentially equates to a potential undertreatment of 32%. So 32% of these men are not receiving radical treatment. Since the NPCA started collecting prospective data in 2014, the value for potential undertreatment has dropped from 39% in 2014 when it started. And we've also seen a further drop to 29% as of last year. So now seeing that a third of patients with high risk or locally advanced disease not receiving treatment does seem quite a high figure. But it's important to highlight that this is a very varied, complex group of patients, ranging from a very fit 60-year-old man to a very frail 92-year-old man for which treatment would be inappropriate. Although the national trend was a decline in the potential undertreatment of prostate cancer, what we also saw was that there was a substantial variation seen across the country in how this patient group was managed. So the aim of this work was we set out to assess the potential reasons for this treatment variation nationally and explore the determinants of treatment. So in terms of our methods, we used the National Prostate Cancer Audit database for this work, which essentially incorporates English cancer registry data linked to radiotherapy and administrative hospital data. Hospital level variation in radical local treatment was explored visually using funnel plots, and the intra-class correlation coefficient, or ICC, was used to quantify the between hospital variation. So in terms of our results, we showed that there were 53,888 men diagnosed at 128 hospitals between 2014 and 2017. And this corresponds to 35,034 that received radical local treatment. So this was 65%. We found the likelihood of receiving radical local treatment was increased in men who were younger, the strongest predictor, and those with fewer comorbidities, as you would expect. But what was surprising is we found that men who were more affluent or those of a non-Black ethnic background were more likely to receive radical treatment as well. Specifically, 60.8% of Black men received radical treatment compared to 65.1% of white men. And this corresponds to an adjusted odds ratio of 0.75 and a 95% confidence interval of 0.66 to 0.86. And also 60.6% of men in the most deprived socioeconomic deprivation status quintile received radical therapy compared to 67.7% of men in the least deprived quintile. So this was an adjusted odds ratio of 0.69 with confidence intervals of 0.63 to 0.75. So to show some figures from the paper, the first figure here on the left shows that variation in the proportion of men receiving radical treatment for men aged 80 years and older. Now the spots represent each hospital and their wide spread indicates the variation seen across the country for elderly patients. This is for patients older than 80. Now the funnel plots for the younger age groups showed significantly less variation across the country. So the second figure on the right shows the respective intra-class correlation coefficients for strata of specific variables that we looked at. So the higher ICC for men aged 80 years and older indicates that there was more between hospital variation for these patients compared to younger age groups. Now, comorbidity and socioeconomic deprivation did not influence the between hospital variation. Now, ethnicity could not be explored in this way due to low patient numbers in minority ethnic group strata. So as some discussion points from the work that we did, as expected, age was found to be a major determinant of radical local treatment in men with high risk or locally advanced prostate cancer. And this effect of age cannot be fully explained by the presence of comorbidities. So for example, we found that the number of comorbidities had only a relatively small effect on the age below which at least 50% of men received radical local treatment. So this suggests that age, rather than life expectancy, is an important factor determining whether men receive radical local treatment. The observation of between hospital variation for patients older than 80 is likely a reflection of the professional uncertainty and the paucity of data about whether or not radical treatment is beneficial in this age group. A finding which has also been seen in other cancers, especially colorectal cancer. It is also important to note that we did not find that comorbidity impacted on the between hospital variation, whilst both of these factors do have an impact on life expectancy, again indicating that age alone is likely governing treatment decisions in this age group. So the important message here is that older patients should be managed according to their individual health status and not based on their age alone. However, this is easier said than done, given that determining a patient's physical fitness and life expectancy is particularly challenging. It is likely that inconsistencies in how these are assessed, if at all, goes some way to explaining why there was an observed increase in variation for patients older than 80. Now, structured geriatric assessments are one such way to assess and optimize fitness for active cancer treatment. And it also has been shown that recommendations from clinicians to their patients are strong determinants of why older patients accept or decline cancer treatment. So this does highlight the importance of shared decision-making in the elderly population with multidisciplinary involvement, including involvement of elderly care specialists. Now, differences in the treatment of prostate cancer with respect to ethnicity and socioeconomic deprivation was a new finding within the NHS. But it is a finding that has been shown previously within the US health system. It is initially unclear as to how or why this treatment variation occurs within our healthcare system, and further investigatory work is ongoing at specific trusts in England to work out what is happening. To provide further context, disparity in treatment rates of different socio-economic groups was seen on a national scale and did not appear to contribute to any between hospital variation. So essentially, in other words, these differences were similar irrespective of hospital or region across the country. So in conclusion, the proportion of men with high-risk localized or locally advanced prostate cancer receiving radical local treatment in the English NHS depended strongly on age and comorbidity, which you'd expect, but also on socioeconomic deprivation and ethnicity. We also found that there is a large variation between hospitals in how older patients are managed. And to end, these findings demonstrate the need for a detailed review of treatment patterns in men with high risk or locally advanced prostate cancer to reduce the risk of undertreatment, and that's specifically related to age, ethnicity, and socioeconomic deprivation. So that's essentially the work we've done as a brief overview. And thank you for the opportunity to speak today.